Hi, nice to see you again. I am Dr. Chengzi the Orange. In our last video, we talked about how cancer forms and develops. It is not an overnight event. It is a long and complicated journey. And precisely because it is long, it gives us something very important: time. Time to detect it, time to diagnose it, time to treat it early. Today, we are going to talk about that window of opportunity, early detection and diagnosis. Let me begin with a personal story, only marginally related to cancer, but highly relevant to early detection. I have always liked sweet food. When I was about 13 years old, cavities formed in one of my molars. At the beginning, the tooth was sensitive to hot, cold, sour, and sweet. I endured it. After 2 or 3 months, chewing and biting became extremely uncomfortable. I endured that too. Another month or two passed, and the pain escalated into unbearable toothache. My entire mouth felt like it was on fire, accompanied by a grinding headache. Incredibly, I still endured. The torture finally ended several days later, when a fistula formed on my gingiva. It stayed there for quite a while and looked frightening, almost like a cancerous lesion. Alarmed, my mother finally took me to see a doctor, which led us straight to a dentist's office. Later, after I went to college, I shared this story with my roommates. Can you imagine? 2 out of 5 had almost identical experiences. Does this give you a sense of how tough people of my generation in China were? We were trained, mentally and culturally, to endure cold, heat, hunger, fatigue, disease, and pain. Almost everything. One consequence of this endurance culture was that many diseases, including cancer, were often detected only at late stages. So what is the takeaway from this story? Pay attention to your body. Do not ignore small problems. If you have frequent difficulty swallowing and solve it by washing food down with water or soup, don't. See a doctor. The esophagus may be in trouble. If stomach pain or acid reflux lingers for a long time and you rely on antacids, don't. The stomach or duodenum may need evaluation. Frequent constipation with blood in the stool? The colon and rectum should be checked. Headaches that worsen over time? Don't just take migraine medication. Doctors may need to rule out problems in the brain. Lower abdominal pain or abnormal inflammatory discharge in women? Don't rely on hot water bottles alone. Exams of the uterus and ovaries may be necessary. Always tired and frequently catching colds? Don't assume it's just aging. Blood tests and sometimes even bone marrow exams may be required. In short, don't try to be Superman or Superwoman. Don't wait until minor problems become serious ones. But medicine has gone one step further. We don't always have to wait for symptoms. There are strategies designed to detect cancer before symptoms ever appear. That is called cancer screening. So how is cancer screened? Broadly speaking, we can think about it in 2 ways: detection initiated by individuals and detection initiated by professional healthcare systems. Let's begin with the first one. Many cancers are first detected by the patient themselves. Perhaps screening is not even the perfect word. It is more accurate to call it self-awareness-based early detection. Some cancers are particularly suitable for this. Breast cancer, for example, is one of the best candidates for self-examination or even partner-assisted examination. Women with dense breast tissue have a higher risk and are encouraged to become familiar with their own normal texture so they can notice changes. Skin cancer, both melanoma and non-melanoma, are visible. They change on the surface. The ABCD rule helps: asymmetry, border irregularity, color variation, diameter larger than 6 millimeters, and evolving over time. The image on the right shows how to use the ABCDE rule to distinguish a benign mole from melanoma. Testicular cancer is another example. Young men between 15 and 35 should be cautious about painless lumps, firmness, or changes in size. Oral cancers can sometimes be noticed as white patches, red patches, non-healing sores, or persistent pain. Dentists routinely screen for this during checkups. Even thyroid cancer may present as visible asymmetry in the neck or unusual movement when swallowing. Self-awareness matters. However, most cancers are detected through professional healthcare systems. The most common method is opportunistic screening during routine primary care visits. When you see your primary care physician, they follow established guidelines. such as those from the U.S. Preventive Services Task Force, and recommend age-appropriate tests, mammography, colonoscopy or stool testing, pap tests and HPV testing, or low-dose CT for high-risk smokers. Many young people skip routine physical exams to save on premiums or time, but routine exams is important. My own primary care doctor once told me that almost every year she detects 1 or 2 breast cancers during annual examinations. Beyond opportunistic screening, there are organized health system programs. Large systems such as Kaiser Permanente use electronic health records to automatically identify patients due for screening. Reminders are sent through secure portals, text messages, automated calls, or even mailed FIT, fecal immunochemical test kits. Screening becomes proactive rather than passive. Some workplaces like Walmart or Microsoft also integrate cancer screening into employee wellness programs. Mobile mammography vans, health fairs, insurance incentives, and mailed colorectal screening kits all lower the barrier to preventive care. In some cases, an employer's health insurance provider, such as Blue Cross Blue Shield, will proactively send reminders to employees who are due for screening. They may even monitor completion rates, not to intrude, but to strengthen preventive care engagement across the workforce. And then there is research-based screening, less common for the general public, but profoundly influential. A landmark example is the National Lung Screening Trial conducted in the United States between 2002 and 2010. More than 50,000 high-risk smokers were enrolled to compare annual low-dose CT scans with standard chest X-rays. The results were striking. Low-dose CT screening significantly reduced lung cancer mortality. Those findings did not remain confined to academic journals. They reshaped clinical practice, ultimately leading to national guideline recommendations for lung cancer screening in high-risk individuals. Earlier, I mentioned high-risk smokers in the lung screening trial. That naturally leads to a question: what exactly does high risk mean? In general, risk comes from 2 major sources: genetics and environmental or occupational exposure. Let's start with genetics. Some families carry a heavier burden. You may see multiple close relatives diagnosed with the same cancer, or cancers appear at unusually young ages, or one individual developing more than one primary cancer. In these cases, the families may have inherited mutations in cancer susceptibility genes, such as BRCA1, BRCA2, MLH1, MSH2, TP53, and need specific screening. For example, women in the general population have about a 12-13% lifetime risk of developing breast cancer. But carriers of certain BRCA1 mutations may face a lifetime risk of 60-80%. That is a huge difference. Because of advances in genetics, we can now analyze dozens of inherited cancer predisposition genes from a single blood or saliva sample. If a pathogenic mutation is identified, such as in BRCA1 or BRCA2, surveillance becomes earlier, more intensive, and more personalized. In certain high-risk situations, preventive, risk-reducing surgery may even be considered. The most well-known example is Angelina Jolie, who carries a BRCA1 mutation and has a strong family history of breast and ovarian cancer. She chose to undergo preventive bilateral mastectomy, later followed by preventive removal of her ovaries and fallopian tubes. Her decision brought global attention to genetic risk assessment and preventive strategies. The second major source of high risk comes from environmental or occupational exposure. Certain professions, miners, firefighters, nuclear industry workers, oil and gas workers, construction workers, and some medical personnel, face increased exposure to carcinogens or radiation. These individuals may qualify for enhanced medical surveillance programs. For example, firefighters are routinely exposed to smoke containing benzene, formaldehyde, asbestos, and other carcinogens released from burning buildings and synthetic materials. In response, many fire departments across the United States have implemented structured health monitoring programs. These may include annual physical examinations, cancer risk assessments, low-dose CT scans for lung cancer, regular skin examinations, prostate cancer screening, and blood tests to monitor hematologic health. Up to now, we talked about how cancer screening happens, then which cancers are actually included in the main screening programs in the United States. According to the National Cancer Institute, the answer is only 5 cancers currently have well-established population-level screening recommendations. Let's call them the Big Five. First is breast cancer screening. This is one of the most established screening programs. Most expert groups generally recommend that women begin breast cancer screening around age 40, usually using mammography. Second is cervical cancer screening. Cervical screening is special because it doesn't just detect cancer. It can detect precancer and prevent cancer from ever forming. The main tools are the PAP test and the HPV test, used alone or in combination. Expert groups generally recommend starting at age 21 and ending around age 65, assuming adequate prior screening and no special high-risk factors. Third is colorectal cancer screening. This can be done with several methods: colonoscopy, sigmoidoscopy, and stool-based tests such as high-sensitivity fecal occult blood tests or FIT tests. For people at average risk, expert groups generally recommend routine screening from about age 45 through 75. Fourth is lung cancer screening. This one is not for everyone. It is mainly for people with significant smoking history, what we call high-risk current or former heavy smokers. The screening method is low-dose CT, and expert groups generally recommend it for certain individuals in the age range of about 50 to 80. And then there is prostate cancer screening, perhaps the most selective and certainly one of the most debated. The primary tool is the PSA, prostate-specific antigen blood test, sometimes accompanied by a digital rectal exam. Unlike some other screening programs, prostate cancer screening is not universally recommended for all men. Many professional guidelines emphasize shared decision-making, a thoughtful conversation between patient and physician about potential benefits and risks. However, for certain higher risk groups, including African American men and those with a family history of prostate cancer, screening may be recommended or more strongly considered. Now here comes an important nuance. The Big Five screening programs are the broad population level recommendations. However, if a person is at increased risk for certain cancers, there are additional screening strategies that may be used. Here are a few examples. Liver cancer screening. For individuals at high risk, especially those with chronic liver disease, screening may be recommended every 6 months. This often includes an ultrasound of the liver, sometimes combined with an AFP alpha-fetoprotein blood test. Ovarian cancer screening is tricky. For the general population, routine screening is not recommended. But in high-risk women, for example, BRCA mutation carriers or people with Lynch syndrome, doctors sometimes use CA-125 blood tests together with transvaginal ultrasound as part of closer surveillance. It is not perfect, but for high-risk groups, clinicians may still use it in practice. For people with higher risk, fair skin, many moles, a personal or family history of skin cancer, significant sun or tanning bed exposure, annual skin checks by a dermatologist are commonly advised. And of course, anyone with a new or changing lesion should be evaluated promptly. Now, after hearing all this, a very natural question is, there are more than 40 types of cancer. Why only Big Five is included in the major screening program? Is it because the others are less serious? No. Screening is not created simply because a cancer is deadly. For a cancer to qualify for population-level screening, several strict conditions must be met. First, the cancer must be sufficiently common. Second, it must have a detectable early stage, ideally a precancerous stage. Third, the screening test must be reliable, affordable, and safe. And most importantly, early detection must clearly improve survival. Take cervical cancer as an example. It usually develops slowly through precancerous changes caused by persistent HPV infection. PAP testing and HPV testing allow doctors to detect abnormal cells years before invasive cancer forms. Treating those precancerous lesions with LEEP, loop electrosurgical excision procedure, cold knife conization, cryotherapy, or laser ablation can prevent cancer entirely. That is why cervical cancer incidence and mortality have dropped dramatically in countries with organized screening. Now compare this with pancreatic cancer. Pancreatic cancer is aggressive and often silent in early stages. By the time symptoms appear, the disease is often advanced. Although pancreatic cancer is one of the best treatable cancers at early stages, pancreatic cancer is considered relatively rare in the general population, affecting roughly 12 to 13 out of every 100,000 people annually. It accounts for less than 3% of all new cancer cases. Screening or diagnostic tests, including imaging, CT, MRI, and blood markers, CA-19-9, on millions of healthy people would be enormously expensive. It also often mistakes benign pancreatic cysts, inflammation, or other conditions for cancer, leading to unneeded, risky, and invasive follow-up tests. Essentially, there are currently limited data demonstrating that early detection improves overall survival. That is the fundamental reason why many serious cancers, including liver cancer, bladder cancer, kidney cancer, brain cancer, and lymphoma, are not included in the main population-based screening programs. You may still wonder, does screening for just the big five truly make a difference? The answer is yes, and we have data to support that. A major study published in JAMA Oncology in December 2024 estimated that cancer screening, combined with advances in prevention and treatment, helped avert approximately 4.75 million deaths in the United States between 1975 and 2020. Cervical cancer offers a powerful example. Before the 1970s, it was one of the leading causes of cancer death in women. Today, due to screening and HPV vaccination, it accounts for only a very small fraction of new cancer cases, only 0.7% of all new cancer cases in 2025. Sometimes the impact becomes clearer when we compare countries. Here is a comparison between the US and China. In the United States, organized screening programs for cervical, breast, and colorectal cancer began decades ago and gradually became widespread. In China, large-scale population screening was implemented much later and remains uneven across regions. As a result, patients in China are often diagnosed at more advanced stages, and 5-year survival rates for several cancers remain lower compared with the US. Then what if you worry about cancers beyond the big five? There are options. Let's talk about the options in the US first. Many companies are developing multi-cancer early detection, MCD tests, designed to detect multiple cancers simultaneously. These tests are usually blood-based and analyze circulating tumor DNA, ctDNA, or other cancer-associated biomarkers released into the bloodstream by tumor cells. MCED tests are intended primarily for asymptomatic adults, usually middle-aged or older individuals at average or elevated risk. However, they are not currently part of standard U.S. cancer screening guidelines and are not included in routine clinical care. Although some MCED tests are commercially available in limited settings, they are still considered investigational. None has yet received FDA approval, and they are typically not covered by medical insurance. Some of the most representative MCED tests include Gallery, developed by Grail in the United States. It works by identifying abnormal DNA methylation patterns, molecular fingerprints shed by cancer cells into the bloodstream. The goal is to detect signals from more than 50 types of cancer in people without symptoms. Another well-known investigational test is CancerSeek, developed by researchers at Johns Hopkins University, that screens for 8 common cancer types: ovary, liver, stomach, pancreas, esophagus, colorectum, lung, breast. It demonstrates over 99% specificity and an overall sensitivity of approximately 70%, with the goal of detecting cancers at an early stage. CancerGuard TM, developed by Exact Sciences, the company behind Cologuard, is a blood-based multi-cancer early detection platform. With a simple blood draw, the test can identify signals from more than 50 cancer types and subtypes, including cancers responsible for over 80% of annual cancer diagnoses in the United States. These include several high-mortality cancers such as pancreatic, ovarian, liver, esophageal, lung, and stomach cancers. Cancer detection through blood-based testing is a rapidly growing field. Globally, several dozen companies, such as Synclera Genomics, developer of Panseer, RGCC International, and Adela, are all working toward the same ambitious goal, detecting many cancers with a single blood draw. Now, as we know, countries like China and India operate quite differently from the US. Healthcare model. So, what happens there if an asymptomatic individual wants to check the whole body for cancer? It is often pursued through comprehensive imaging packages and bundled blood tests. One common approach is whole body MRI. Some large hospitals and private health centers offer full body MRI scans as part of premium health check packages. The appeal is clear, detailed imaging without exposure to radiation. Another method sometimes offered, especially in high-end centers, is PET-CT scanning. PET-CT detects areas of high metabolic activity, and many cancers appear bright on these scans. The drawbacks? Both approaches are expensive, and PET-CT involves significant radiation exposure. In major cities such as Beijing, Shanghai, Mumbai, Delhi, or Bangalore, private hospitals commonly offer annual executive physical exams. These are full-body checkups that combine imaging and laboratory testing. They may include chest CT, abdominal ultrasound, thyroid ultrasound, tumor marker panels, optional gastroscopy or colonoscopy, and sometimes low-dose CT. Tumor marker panels often include blood tests measuring substances such as AFP, liver cancer, CEA, colon and others, CA125, ovarian, CA99, pancreatic, PSA, prostate, CA15-3, breast, and CYFRA-21-1, lung. These tests are frequently bundled together and marketed as comprehensive cancer blood screening. So there are options for early cancer detection beyond standard guideline recommendations. However, this brings us to an important question. Why not screen everyone for everything? Because screening everything is not automatically beneficial. First, when a disease is rare in the general population, even a very good test will inevitably produce false positives. For example, an indeterminate thyroid nodule detected on whole-body imaging may lead to needle aspiration, repeated ultrasounds, or even surgery. During this process, patients may experience significant psychological stress, radiation exposure from follow-up scans, procedural risks such as bleeding or infection, and substantial financial costs, all for a condition that ultimately proves to be benign. Second, there is the issue of overdiagnosis and overtreatment. Some cancers grow so slowly that they would never cause harm during a person's lifetime. Prostate cancer is a classic example. Widespread PSA screening detects many indolent tumors. Some men undergo surgery or radiation for cancers that might never have affected them, resulting in side effects such as urinary incontinence or erectile dysfunction. In such cases, treatment may cause more harm than the disease itself. Third, screening only makes sense if early treatment meaningfully improves outcomes. Consider aggressive brain cancers such as glioblastoma. These tumors grow rapidly and invade surrounding brain tissue. Even with early diagnosis and intensive treatment, long-term survival remains poor. If detecting a cancer slightly earlier does not substantially change prognosis, the value of screening may be limited. So in reality, screening every possible cancer isn't recommended. It can bring physical, psychological, and financial costs, and the harms may outweigh the benefits. But if someone understands the limitations and still wants to do it, that choice ultimately belongs to them. Now let's imagine that screening detects something abnormal. The next step is diagnosis. Diagnosis is a structured process. It usually begins with a medical history and physical examination. Doctors ask about symptoms, family history, smoking, occupational exposures, and many other details. Sometimes a simple exam, feeling a lump, listening to the lungs, or checking lymph nodes already provides important clues. Next come laboratory tests and imaging. Blood tests may reveal anemia or organ dysfunction. Imaging tools such as ultrasound, Connecticut, MRI, or PET scans help doctors see where an abnormality is, how large it is, and whether it has spread. But imaging alone usually cannot prove cancer. The most critical step is often the biopsy, removing a small sample of tissue so a pathologist can examine it under the microscope. By studying the cells, their structure, and sometimes their molecular features, pathologists can determine whether the tissue is cancerous and what type of cancer it is. Once the diagnosis is established, doctors then determine the stage, how large the tumor is, whether lymph nodes are involved, and whether the cancer has spread. Staging is essential because treatment decisions depend heavily on it. We are coming to the end of this talk. In our next video, we will focus on surgical treatment of cancer, when and how surgery is used, and why it remains one of the most powerful tools in oncology. Thank you for watching. See you soon.